What's up team? It has been a minute. It's been some time since I made a video, and that's because I've been enjoying my best post GSSE life. But we're back today with a video on cardiac physiology. Now if you recall, I mentioned that physiology and pathology are the two topics which people fail on most frequently, so it makes sense to give them the most amount of attention. So in this video we'll be going through some core topics, some high yield topics for cardiac physiology, and hopefully it gives you guys a bit of a hand. Slightly different style of video this time. We're doing a lot of drawing on the screen, so let me know if you guys enjoy that as well, or if you find it annoying. It's got a little like sign around the cursor, which I don't particularly like, so I'll be trying to get rid of that for future ones. But again, as always, I'm looking for your feedback rather than mine, so let me know if it works for you, let me know if you enjoy it. It's not meant to be a all-inclusive kind of package for you. It's mostly just revision, so use it as revision and supplement it with your own learning as well. Having said that, if you have tips and tricks on how I can improve my videos, please let me know. That's pretty much it from me. We can just get straight into the video, and I hope you guys enjoy it.
To begin, let's quickly cover some foundational concepts and definitions. So, we'll start with mean arterial pressure, which is the average pressure throughout the entire cardiac cycle. Now this is equal to cardiac output multiplied by total peripheral resistance, or systemic vascular resistance. They're the same thing. So we can break this down a little bit further. So cardiac output is equal to stroke volume multiplied by heart rate. And our stroke volume can be further broken down into end diastolic volume minus our end systolic volume. So the amount of blood in the heart just prior to it ejecting, and the amount of blood in the heart at the end of its ejection. And these values are usually around about 120 mils minus around about 50 mils, which leaves us with an average stroke volume of around about 70 mils. Now, our total peripheral resistance is the measure of resistance within the vessels. So this is governed by the constriction of the vessels, and the constriction can be changed, whether it be by pharmacological means or neuronal means, and also the viscosity of the blood. Usually we're most concerned with the constriction of the vessels, because that's what we can change using our medications or using the body's physiology. So now that we've got this kind of down pat, we can start to discuss the receptors implicated in cardiac physiology. When alpha-1 receptors are activated, they cause a lot of blood vessel constriction. So these come in. And the effect that this has is that it elevates our blood pressure, and primarily does so by elevating our systolic blood pressure. And if we think back to our MAP equation, so MAP equals cardiac output times total peripheral resistance, what we're actually doing is increasing the total peripheral resistance by increasing the vasoconstriction of the vessels, therefore making it harder for blood to flow through vessels. And that's why we get an increase in our systolic blood pressure. Beta-1 receptors, what they do is they increase the contractility of the heart. So they make the heart pump harder. What this does is it also increases our blood pressure. Also by similar means, by increasing our systolic blood pressure. But it doesn't do so to the same extent as our alpha-1 receptors. It does so to a lesser extent. And finally, beta-2, they cause a lot of vasodilation. So these go out rather than in. But it also increases our chronotropy, so our heart rate. The overall effect of this is that we actually get a reduction in our blood pressure, and this is primarily by reducing our diastolic blood pressure. And this effect is so because of the vasodilation effect of our beta-2 receptors. Now that we've discussed all of the receptors, we can discuss the effect that different catecholamines have on the actual system. So the catecholamines we'll discuss will be noradrenaline, adrenaline, dobutamine, and for exam purposes, dobutamine acts the same as isoprenolol, or dopamine. So let's create a little table here. Okay, I hope you like my wonky table here. So we'll start with noradrenaline. Its receptor affinity is that it likes alpha receptors much more than it likes beta receptors. What effect does this have? So alpha receptors, we talked that they produce a lot of vasoconstriction, so they are going to cause our systolic blood pressure to rise quite a fair bit. They'll also cause our diastolic blood pressure to rise for the same reasons. Now the total peripheral resistance as a result of all of this will again rise, and so will our MAP. Now it would be reasonable for the heart rate to also rise, because noradrenaline does still have some beta adrenergic effects, and beta does cause increased chronotropy and inotropy. So we would normally expect the heart rate to rise, and it does initially. So initially we get a rise in our heart rate, but what happens eventually is that our baroreceptor reflex kicks in, and we actually end up getting an overall reduction in our heart rate. We'll discuss baroreceptors in a minute. I'll just complete the rest of this table. So for adrenaline, it's got roughly equal alpha and beta activity, which means that it's still going to cause an increase in our systolic blood pressure. It's still going to cause some increase in diastolic pressure, but because its beta effects are much greater than noradrenaline, we're actually going to get a bit of vasodilation. So overall, our diastolic blood pressure ends up falling. Our total peripheral resistance, for similar reasons, also ends up falling because of the vasodilation. And our MAP ends up having not much of a difference because we've got an increase in our systolic blood pressure, but a decrease in our diastolic and our TPR. So the overall effect is that there's not much of a change in our MAP. But because of the actions on the beta receptors, we end up getting an increase in our heart rate. Now, dobutamine is much more of a beta agonist than it is an alpha agonist. Because of that, we're going to get maybe a slight increase in our diastolic blood pressure, and this is a beta-mediated effect with an increase in the contractility, but we're going to get a reduction in our diastolic blood pressure because of all of the beta effects and the vasodilation. We're therefore going to get a reduction in our total peripheral resistance, again because of the overall increased vasodilation, and our MAP is going to fall. But again, because of the beta effects that we have with increasing chronotropy and inotropy, we're going to get an increase in the heart rate. And again, for exam purposes, remember that dobutamine and isoprenolol are effectively the same, or have the same effects. Finally, dopamine. So dopamine actually has its own receptors, so it acts primarily on the dopa receptors, but it does also act on alpha and beta. Its overall effects result in an increase in our systolic blood pressure, and this is mediated by the beta and the alpha receptors. It causes a net nil change with our diastolic blood pressure, and a net decrease because of our due to its effects on the dopamine receptor. You're not going to need to know much more than this for the exams or as far as the past questions go, so I'll just leave it there. Now let's discuss the noradrenaline effects with regards to the baroreceptor reflex. So initially, when norad is first introduced into the body, we get an increase in the heart rate. And this is mediated by the beta receptors. However, because of the massive increase in TPR and MAP that we get, because of the alpha effects and partly the beta effects, there's a baroreceptor reflex that kicks in. Remember that the baroreceptors are these receptors which are found in the aortic arch, and they're stretch receptors which are found in the aortic arch, and also at the bifurcation of the internal and external carotid arteries. So we've got some stretch baroreceptors in the carotid sinus here, and these are mediated by the glossopharyngeal nerve. And we've got some baroreceptors, stretch baroreceptors in the aortic arch here, which are mediated by the vagus nerve. The baroreceptors sense the increase in the mean arterial pressure, or the atrial pressure, and they stretch, increase stretch, which results in them increasing their firing. By increasing their firing, we actually end up getting increased vagal activity and reduced sympathetic activity, which in turn reduces our heart rate, which is why the overall effect is a reduction in heart rate when noradrenaline is used. Before we move on to some questions, let's discuss vasoactive agents, including constrictors and vasodilators. We'll start off easy with some of the stuff that we've already discussed. So we know that noradrenaline, so Na, is a vasoconstrictor. So is adrenaline. Now adrenaline is kind of funny because it acts on alpha to cause our vasoconstriction, but it also acts on beta to cause some vasodilation. So it does a little bit of both. Dobutamine also ends up falling in the vasodilator section due to its effects on beta. Something that should be pretty obvious to all of us is that exercise causes vasodilation, and this is through increasing temperature and also pH. So by having lactic acidosis, or acid produced from the muscle cells, we want to increase the dilation around those muscle cells to allow for nutrients to come in and for waste products to go out. Does that make sense there? Similarly, if increased temperature causes vasodilation, then it would serve as correct that decreasing temperature would cause vasoconstriction. And this is again true. So when you go out into the snowfields, you'll see that your hands get nice and cold, and that's because of the vasoconstriction that happens peripherally. Some other vasoconstrictors that we might be reasonably well aware of would be angiotensin II. So angiotensin II. We know this to be true because we know that angiotensin II causes an increase in blood pressure. And how does it do that? It does so, one of the ways that it does so is by vasoconstriction. Then on the other side, for our vasodilators, we've got a fair few number of molecules and hormones, including nitric oxide. So this is one of the primary ingredients in a lot of gym supplements, which causes vasodilation to try and get more nutrients to the muscle cells as you're working out. We've got prostacyclin. Prostacyclin. We've got histamine. This should be familiar to a lot of people. Histamine causes widespread degranulation, resulting in vasodilation. And atrial natriuretic peptide. So ANP, by the virtue of its name, causes an increase in diuresis. One of the ways it does this is by vasodilation around the kidney. So the kidney vessels become vasodilated, GFR increases, and we end up filtering more fluid and therefore peeing out more. And again, on the other end of the spectrum, we've got substances such as serotonin and thromboxane A2, which cause vasoconstriction. Now, this is by no means an exhaustive list. There's a much larger table out there which has all the vasoactive agents, but these are the ones that you'll commonly come across in your GSSE questions. So remembering these is going to be quite useful for you. Moving on to some questions. Here we've got a question regarding sympathomimetic amines. So question 1, dopamine acts on alpha, beta 1, beta 2, and specific dopaminergic receptors. We know this to be true based on the table that we drew before. So this is going to be true. So dopa does indeed act on primarily on dopa receptors, but also ends up acting on alpha and beta. So that's true. Isoprenolol acts predominantly on beta 1 and beta 2 adrenergic receptors. This is also true. So we discussed that dobutamine and isoprenolol are primarily beta agonists. However, they do still have some alpha activity, but they are by far much more of a beta agonist than they are an alpha agonist. Next, noradrenaline has little to no effect on alpha adrenergic receptors. This is definitely false. So noradrenaline is primarily an alpha agonist, whereas adrenaline has equal alpha and beta activity. So this question is false because NORAD is primarily alpha, which increases our systemic vascular resistance, increases our MAP, increases our TPR, our blood pressure, but causes a reduction in our heart rate because of the baroreceptor reflex. And finally, adrenaline acts on alpha, beta 1, and beta 2, and this is true. This question doesn't actually ask us whether it has more of an affinity for one or the other, so it's just asking us whether it does act on them, and it definitely is true. Adrenaline does indeed act on alpha, beta 1, and beta 2 agonists. So this question is going to be true, true, false, true. Let's talk about cardiac conduction. So we've got a heart here with our left and right atria and our ventricles. Now, we know that normally our conduction starts at the SA node, which is found in the right atrium here, and passes through to the atrial myocardium, eventually into the AV node, which is found around about here, into the bundles of His, which run down the interventricular septum, into the right and left bundles, through here, and then finally into the Purkinje fibers along the ventricles. Overall, our conduction ends up going from here to here to here to here. So from the right atrium to the left atrium to the left ventricle and to the right ventricle. And the depolarization spreads from in to out. So we're getting spread from the endocardium into the epicardium. And eventually the contraction ends up going from the apex through to the base. So the start of the heart, effectively. So the last part to depolarize is actually the pulmonary conus up here, the top of the intraventricular septum here, and the posterior parts of the left ventricle, so around about here. Now, of course, the atria have contracted before the ventricles in order to push the blood into the ventricles to allow for ejection to occur. So with regards to what I've just talked about, this is the ventricle contracting right at the end. In terms of the contraction order of the right ventricle versus the left ventricle, the right ventricle needs to exceed the pressure within the pulmonary vessels before the pulmonary valve can open, so before this ends up opening. The pressure that it needs to exceed is around about 10 mmHg, so 10 millimeters of mercury. Within the left ventricle, we need to exceed the minimum pressure of the aorta in order for the aortic valve to end up opening and for blood to be ejected. Now, that minimum pressure is the diastolic blood pressure, which is 80 millimeters of mercury. So it stands to reason that the right side of the heart is going to eject its blood first. So the right ventricle is going to open first. The peak pressure of the pulmonary system is around about 25 millimeters of mercury. Whereas within the left side of the system, the peak pressure is around about 120 millimeters of mercury. And again, this is in a normal, healthy adult. But the pressure that is needed to be exceeded before ejection actually occurs is 80. Therefore, the right ventricle ejects first before the left ventricle. There's a fair few questions on heart failure. Now, heart failure can be thought of in terms of heart failure with preserved ejection fraction versus heart failure with reduced ejection fraction, or the more, classical way of thinking about it, or the older school way of thinking about it, which is left-sided heart failure or right-sided heart failure. Now, both of these have a failing heart, but the difference is the way that the left ventricle has adapted to the changes within the body. So in heart failure with preserved ejection fraction, our ejection fraction remains normal because our left ventricle has stiffened and is very strong, so it has strong contractions. So our ventricle has little space left within it because of the thickness of the ventricular wall. But when this contracts, we can eject a large amount of the actual volume that is left within the ventricle. So our end diastolic volume is actually lowered, but our end systolic volume also remains low, which means that our stroke volume, which is a function of EdV minus ESV, remains normal. The other thing we need to know is that because of this thickened ventricular wall, in order for the left atrium to pump blood into here, we are actually going to need to overcome larger pressures. So we have an increase in the diastolic filling pressures. This is distinct to heart failure with a reduced ejection fraction. So with a reduced ejection fraction, what we have is a ventricle that is blown out and thin and does not contract well. So it's a dilated LV and we've got poor contraction. Unlike in heart failure with preserved ejection fraction, our end diastolic volume here is actually greatly increased. We've got a lot more room because the left ventricle has ballooned out. And because our contraction is so poor, our end systolic volume also ends up remaining quite high, which means that our stroke volume, which equals EDV minus ESV, ends up reducing. Now, interestingly, in heart failure with reduced ejection fraction, we still have an increased diastolic filling pressure, but this time it's due to this sheer volume that we can actually fill into this left ventricle, rather than the pressure that we're pushing against. So overall, diastolic filling pressure does end up increasing because of the increased volume within the left ventricle. So that's one way of thinking about heart failure. The other way of thinking about heart failure is to think about it in terms of a left-sided heart failure or a right-sided heart failure. Okay, so all of this, heart failure with reduced or preserved ejection fraction, pertain to left-sided heart failure. The other way we can think about things is thinking about them in terms of a left or versus a right-sided heart failure. Now, the left-sided heart failure is going to cause quite acute and rapid symptoms. Why is this? This is because if the left side of the heart begins to fail, the blood will be backed up within the pulmonary system. Now, the lungs actually don't have that much volume compared to the vasculature. So we're going to cause an overload of the lungs quite quickly and run into troubles with acute pulmonary edema. And this is going to result in rapid symptoms within the patient. Whereas if our right ventricle begins to fail, this is actually going to take some time, so it's going to be a slow burn. And this is because the peripheral vasculature, so within the legs and within the arms, there's a lot of room for which the fluid can distribute peripherally. Therefore, it'll take some time before the symptoms are noted, or rather the signs are noted, and the patient becomes symptomatic. So you'll see people who have ankle edema, but isn't really causing much problem for them. It's only when the right-sided heart failure has been going on for some time and the congestion gets really bad that they become symptomatic and the heart failure becomes something that we as clinicians end up seeing and needing to treat. Okay, let's blitz through some questions. Now remember, with all of these true-false type questions, all you're really looking for is one piece of fact, which is indeed false, and that negates the entire question. So you don't really need to think too hard about the rest of the question if you've already found a piece of it that is false. So, for concerning the conducting system of the heart, stimulation of cholinergic vagal fibers to nodal tissue decreases potassium ion conductance. Now you should know that it's not potassium ions that determine conductance, it is sodium ions. So even if you don't know whether it's cholinergic vagal fibers that determine the conductance or that innervate the nodal tissue, by knowing that it's going to be by knowing that it's going to be sodium ions that determine conductance, we know that this answer becomes false. Depolarization of the ventricular muscle starts on the right side of the interventricular septum. Now we've previously drawn a little diagram with our left and right ventricles and talked about how our conductance is going to go this way and our contraction is going to go this way and our depolarization is going to go this way. So we know that the depolarization is actually going to start on the left side of the interventricular septum. That makes this answer false. The last part of the heart to be depolarized is the epicardial surface of the left ventricular apex. So we know that the depolarization goes from the apex, so the first part of the apex, down to the base. So based on that, that makes this answer false. And even if you don't know whether, or you've forgotten whether it was endocardium or epicardium which comes first, because the left ventricular apex part of this question is false, that automatically makes that answer false. And finally, stimulation of the sympathetic cardiac nerves results in an increased intracellular cyclic AMP. Now this is true. We know that sympathetic nerves are going to want to increase our contractility and our conductance. And the way that they do that is by increasing cyclic AMP activity, which increases our calcium within the cells, which increases the contractility. So that makes this answer false, 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 true. In regards to the overall synchronization of the heart, right atrial systole precedes left atrial systole. This is true. Our depolarization is going to start with the SA node within the right atrium, so that is true there. Right ventricular contraction precedes left ventricular contraction. Based on this last question, we know that the depolarization is going to start on the left side of the IV septum, and the left ventricle is going to begin to contract first. However, because of the pressures that we talked about before, so the pulmonary side, so on the RV, we only need to exceed 10 millimeters of mercury for those valves to open. Whereas on the aortic side, so the left ventricle, we need to actually exceed 80 millimeters of mercury before the valves open. Therefore, it stands to reason that the right ventricular ejection does precede left ventricular ejection. And finally, pulmonary valve closure precedes aortic valve closure. Now, without getting too much into this, so during expiration, both the aortic and the pulmonary valve close at the same time. However, during inspiration, the aortic valve closes before the pulmonary valve. And this is partly due to the lower impedance of the pulmonary vascular tree, but you don't really need to know too much about that, or at least I didn't bother learning too much about that. But I just remembered that it's either going to be the same or aortic's going to come first, which is going to make this one false. So this answer is going to be true, false, true, false. All right, moving on to this question. In a failing left ventricle, all the following parameters are reduced except. So this question is essentially looking for the one correct answer rather than all of them being true or false. So we just need to find the first correct answer, and then that we're confident about, and we don't really need to go too much further with that. So if our left ventricle is failing, is our ejection fraction going to be reduced or increased? So if our left ventricle is going to be big and floppy and not contracting very well, then it would stand to reason that our ejection fraction is going to be reduced. Our stroke volume is going to be reduced, and therefore our ejection fraction will also be reduced. Now, the caveat to this is a heart failure with a preserved ejection fraction. However, for the purposes of this question, we can go with this theory to say that it's going to be reduced and see if we can find another answer which more correctly fits in with this question. All right, end systolic volume. So if our left ventricle is failing, is our end systolic volume going to be up or down? So our end systolic volume, if our ejection fraction is decreased, if our stroke volume is decreased, that means our end diastolic volume minus our stroke volume, which is going to be reduced, is equal to our end systolic volume. That means that this number is going to be increased, given that our stroke volume is decreased. So that makes this answer correct. So if I'm confident about this answer, I don't really need to go through the rest of the answers to try and figure out whether they're going to be right or wrong. So I'm happy to move on at this stage, but for yourself, for your learning, you can go back through C, D, and E and try and figure out why they would be incorrect. All right, isometric contraction of the left ventricle. So this is when the left ventricle begins to contract against a closed aortic valve and against a closed mitral valve. So does it occur in the first third of systole? No, so systole is actual left ventricular contraction and ejection. So this can't be true. So this is going to be false. Again, we're just looking for the one correct answer. Involves the most rapid change in pressure per unit time of the cardiac cycle. Absolutely, this is correct. So you are squeezing this bag against a closed surface. So the pressure is going to rise tremendously. So that makes B true. Again, we don't really need to go through the rest of these, so I'll leave you guys to go through that in your own time. And with this final question, so essential differences between cardiac failure with diastolic dysfunction and failure with systolic dysfunction. So systolic dysfunction was heart failure with reduced ejection fraction, and diastolic dysfunction is heart failure with preserved ejection fraction. Include all of the following except. So we're finding one that both HPEF, HFPEF, and HFrEF have the same parameter for. So diastolic filling pressures. Now remember, we talked about how the diastolic filling pressure in both of them are actually increased for different reasons. So this is actually the first correct answer. Now, given that we've got just a little bit of time, I'll quickly go through the end of these. So ejection fraction is going to be, by virtue of their name, different, so that makes that one false. Myocardial wall thickness. So in our stiff LV, we've got a thickened myocardial wall, and that's going to be the one with a preserved ejection fraction. Whereas in our systolic dysfunction, where we've got a flimsy wall, really dilated, that's going to be quite thin. So that makes this false. And if our ejection fraction is going to be different, that means our end diastolic volume and our end systolic volumes both have to be different. So that makes both of these false. So the correct answer here is A. Okay, so let's finish up by discussing the Cushing's reflex. And in order for us to talk about this, we need to briefly touch on cerebral blood flow and cerebral perfusion pressures. So we'll start with cerebral blood flow. So remember previously we've discussed that flow is proportional to our pressure and also our viscosity. And that our pressure we could alter by changing the caliber or the diameter of a vessel of which the fluid is flowing through. So it stands to reason that our cerebral blood flow is going to be influenced by our mean arterial pressures and our mean venous pressures. So this is essentially the inflow and the outflow within the brain. And they are again influenced by the diameter of the vessels that are controlling them. And also the viscosity of the fluid, which is the blood. So viscosity, and finally the ICP, so the intracranial pressure. So just a quick note on our ICPs. So the cranial vault is an area which has a very fixed volume, and it can only hold a certain amount of substance. So if we are to try and fit more stuff in there, more than usual, whether it be fluid or mass, then the pressure within this area, which is the intracranial pressure, will begin to rise. There's a certain amount of compensation that go on, but at some point that pressure will begin to rise. So there's a relationship between the brain tissue, between the CSF and the blood, which is made up of arterial and venous components. The relationship between these three, creating a pressure-volume relationship, is known as the Monro-Kelly doctrine. So Monro-Kelly doctrine. So now let's discuss cerebral perfusion pressures. So CPP is a major determinant of our cerebral blood flow, and autoregulation of this cerebral perfusion pressure ensures that our blood flow, cerebral blood flow remains constant over a wide range of map. So this means that kind of no matter what we're doing, hopefully within reason, that our blood receives the same amount of blood flow throughout all of our different activities, all of our different postures, whether we're supine, standing, etc. We've discussed already how the cranial vault is a fixed volume space, so fixed volume. And the body can regulate the amount, the pressure within here. The way that it regulates that is we've discussed how part of this fixed space is CSF and part of it is venous blood. So what the body can do is it can alter the amount of CSF and the amount of venous blood within this fixed vault in order to keep the ICP the same, in order to keep cerebral perfusion pressure within limits so that our cerebral blood flow can remain constant over this wide range of maps. This allows us to compensate for any extra fluid or mass that may be within this fixed volume cranial vault. Now, if you're asking how does the body actually control these things, that's a very good question. This is all controlled through the rostral ventrolateral medulla, or the vasomotor area. And these are going to be the key words that you see in your GSSE exam questions. So this area receives SNS input in order to maintain the CPP. It can be stimulated by chemoreceptors, carbon dioxide, hypoxia, as well as a couple of other things. But these are going to be the main ones that it's going to be stimulated by. It can also be inhibited by the cortex itself, the caudal ventrolateral medulla, and baroreceptors. So basically, through one of these inputs, either positive or negative, that will be sensed by the RVLM or the vasomotor area, which will alter the amount of SNS output in order to alter the body's map in an attempt to keep our CPP and therefore our CBF within normal limits. So obviously at some point, the body is no longer going to be able to compensate. So when we've got this fixed cranial vault, if our mass is huge, there is going to be a point where we can no longer get rid of any more CSF or no longer get rid of any more venous blood. And this is where our ICPs begin to rise. So within this state, where we've got a smaller mass or a smaller fluid collection, or whatever it may be, the ICP remains normal. So let's call it, for example, 5. So our ICP remains normal. But at some point when the mass is so big that the body is no longer able to compensate, that's when our ICPs will begin to rise. And they might rise to a quite dangerous level. Let's call it 30. When and if our ICPs begin to rise to dangerous levels, what ends up happening is compromised blood supply to the rostroventrolateral medulla or the vasomotor area. The lack of blood supply results in hypoxia. And this hypoxia, we noted, was a positive stimulant for the vasomotor area. So our vasomotor discharge increases. We've discussed that increasing the vasomotor discharge results in increased SNS output. So we get an increased SNS output. And this is in an attempt to increase the systolic blood pressure of the body, in an attempt to increase the cerebral perfusion pressures, in an attempt to increase blood flow back to the RVLM. This is what the body is trying to achieve. But what actually ends up happening is that our MAP increases appropriately because our SNS input is increased. However, our arterial baroreceptors sense the increased MAP and increase their firing. And we've already discussed that increasing arterial baroreceptor firing increases vagal tone. And by increasing our vagal tone, we reduce our heart rate. Now, if you remember back to what happens when we infuse noradrenaline, this is the exact same thing. Our MAP has gone up, therefore our baroreceptors are more stretched. They increase their firing. By increasing their firing, we get increased vagal tone, which reduces our heart rate. That is why noradrenaline can cause a bradycardia or a relative bradycardia. In this case, we're getting the exact same effect. Now, the increased MAP also puts increased pressure onto the brainstem. And the brainstem houses all of our breathing centers. The increased pressure on the breathing centers results in irregular breathing. Now, this combination of hypertension plus bradycardia plus irregular breathing is our Cushing's reflex. And this is why having an intracranial mass can result in the Cushing's reflex. Thank you for coming to my TED Talk. Alright, so let's just finish off with some questions. So it's factors influencing the total cerebral blood flow. So we know that cerebral blood flow is dependent on our mean arterial and our mean venous pressures. And this is from the body itself. So not necessarily just the brain. So we need to know what the mean arterial pressure of the body is and the mean venous pressure of the body is in order to perfuse the brain and produce blood flow. And finally, the viscosity of the fluid, so of the blood. So our cerebral metabolic rate is not going to be an influencer of the total blood flow because our cerebral metabolic rate will not influence any of these. The arterial pressure at the brain level, that is true because that is going to be formed by our map. The adrenergic and the cholinergic nerve fibers. Now, while they will influence the blood vessels, some of the cerebral blood vessels, they're not going to determine the total cerebral blood flow. So this answer is going to be false. And finally, the venous pressure at the brain level, that's going to be our MVP, and that is correct. So this answer is going to be false, true, false, true. Moving on to the second question. So increased intracranial pressure causes hypertension and bradycardia. So this sounds very much like Cushing's, because with increased intracranial pressure, there is stimulation of the vasomotor center due to local accumulation of carbon dioxide. So this is exactly describing the Cushing's reflex. So we have increased ICP, which means reduced blood flow to the vasomotor area, which means increased discharge from the vasomotor area, which means increased SNS, increased MAP, increased arterial baroreceptor firing, resulting in, so our increased MAP ticks this box. Increased arterial baroreceptors means reduced heart rate, which ticks this box. And we've also discussed that the increased MAP results in increased pressure onto the breathing centers within the medulla, resulting in irregular breathing. And the reduced blood flow resulted in increased carbon dioxide buildup around the vasomotor area, which increased its firing. So this perfectly describes Cushing's reflex, which means that our statement is true. S is true. Our reason is true. And our reason explains our statement.
Alright team, that is it. Hopefully you guys really enjoyed that video. I've enjoyed making it. It's a little bit, like I said, different and more difficult to make than the previous ones. But again, let me know what you thought and we'll see you in the next video. Thank you.